Good afternoon, everybody, and thank you for joining us for another in a series of Dean's Lectures, where we can come together and celebrate the newly promoted and appointed professors in the school. Being promoted to professor is a huge accomplishment, a huge achievement, and it's just, I remember talking to Mike and Al about the good things about being dean, and this is clearly one of the good things about being dean, is that you get to introduce faculty who have become full professors to the school community. Many of you know our lecturer today, but others of you may be hearing from Dr. D for the first time. But it's a huge privilege, especially today, to introduce our speaker today, Dr. Sydney D. I have known Sydney for many, many years and have always admired not just her science, but her commitment to translating that science into evidence-based practices that make a real difference for people with serious illnesses and terminal illnesses. Sydney is a researcher and an educator in healthcare quality and safety, focusing on the development, evaluation, and implementation of quality indicators, particularly for patients with serious illness and at the end of life. She has helped develop national quality standards and guidelines with numerous organizations, and has researched the implementation and application of these guidelines in a variety of different settings. I think she's perhaps best known for the work she's done in developing evidence-based quality measures in palliative care, these measures are now widely used throughout the country. She has garnered support for her work from the Centers for Medicare and Medicaid Services, the National Cancer Institute, National Institutes on Aging, the VA, as well as the Agency for Healthcare Quality, Healthcare Research and Quality. Sydney has also played a very important role here at home at Johns Hopkins, where she helped develop and lead many of the first palliative care programs in the hospital, and has served as the medical director for the Hopkins Cancer Symptom Clinic, palliative care, case management, and hospice programs. In 2002, Sydney was appointed an assistant professor in the Department of Health Policy and Management, where I got to know her, and she rose to the rank of professor in 2016. She also holds joint appointments in the Departments of Medicine and Oncology in the School of Medicine. She is core faculty of the Armstrong Institute for Patient Safety and Quality, and is a practicing physician with a primary care for cancer survivors program. I had the privilege of getting to know Sydney as a member of the faculty in health policy and management, and have seen her skills as a teacher firsthand. She teaches core courses in quality of care, as well as in palliative and hospice care. And she is just a terrific advisor and mentor to many of our doctoral and master students. I think of particular note is her contributions to the department's DRPH programs in management and leadership, where she is simply revered by a number of students who go through that program. And I've heard firsthand from those students. She has co-authored over 150 peer-reviewed publications, and she is deputy editor of the Journal of General Internal Medicine, as well as an associate editor for the Journal of Pain and Symptom Management. Sydney earned her bachelor's degree in chemistry summa cum laude from Cornell University, and her medical degree and master's in health services research at Stanford. She then came to Hopkins and did her internship and residency and in internal medicine, and was a Robert Wood Johnson Clinical Scholar. She has received national and international recognition for her work in palliative care, and in 2014 was recognized as a fellow of the American Academy of Hospice and Palliative Medicine. Please join me in giving a warm welcome to Professor Sydney D. Sydney?
Thank you all so much for being here. It's really wonderful to see so many people here. I'm particularly glad that Mike Clegg is here because you may not know he was my clinical division director across the street before I came to the School of Public Health, and supported me in many ways. And I don't know if you remember this, Mike, but I drove him crazy, and he did. I don't know if you remember telling me I would never make it in the field of which you were almost right, but yeah, here I am. So I have so many people to thank. I've spent nearly half my life here at Johns Hopkins, and many people who told me they couldn't be here with me. I appreciate so many people being here with me today. I know that so many of you have been through many of these things yourselves and have many other places to be, but it is really a miracle for you to spend a little time with me here thinking about these issues. And these are three of my heroes that I had the honor of taking care of for months at the end of their life: my grandma and my Zadie. And my dad. That's my Cornell graduation picture. A lot of you have seen. My dad would have been 78 years old this week. So I want to particularly thank, again, so many people here, but particularly Jonathan Weiner and Albert Wu, my mentors, who have both taught me to be optimistic. Jonathan, who's always taught me to speak up, and I was really glad to find this picture. So a lot of you know Albert loves to tweet, and this is us doing a panel presentation together. And I think I am hiding while he's trying to take our picture to tweet it. Oh, I'm so glad you just walked in. Yes, there's Albert. So yes, be careful. He might be tweeting about you. I've had two other, so many leaders, donors, patients, colleagues. A lot of you are here. A lot of our students. I just want to point out a couple pictures. So this is the very first student that patient that we recruited to a research study after I came on the faculty. This was for a study of spirituality in patients with advanced disease, and this was our first patient we recruited, and you might be able to see he was wearing a Jesus hat, so he allowed us to take his picture for the presentation. And then, again, just had an opportunity to have such amazing students here. I know many of whom are here today, and such wonderful support from the department. I know some of you have seen these pictures. We just got to go to India, and Ritu from the 6th floor took us around, and here we are at the Taj Mahal a few weeks ago. Okay, so I want to talk about where end-of-life care has come from, and all the things that have changed and all the things that are really still the same. So Albert, this is not me. This is, the hospice movement really started in the 70s, and then the legislation to start hospice in the United States was passed in 1982. And the final rule went into place in 1983. So hospice, for those of you who aren't aware, is our program really here in the United States designed around end-of-life care that supports people to be at home at the end of their life if that's what they wanted. And this was also the start of the AIDS epidemic, which was really a big part of why hospice and the end-of-life movement came to be. This picture here, the caption reads, "Joe is stricken with grief while visiting Bill. He cries into the bedsheet to keep Bill from seeing him." It's from the Hospice of Marin County, 1982. And Princess Diana really had a big role, not only in acceptance for people with HIV, but really for hospice care and at the end of life. So she spent a lot of time in the mid-'80s in doing this and really normalizing this. For many years, our hospice that we worked with here had a unit down in DC that I used to go down in the weekends, and we had a big picture. Not this one, but a big picture of Princess Diana visiting with the dying AIDS and hospice patients. All right, so I have a poem that I want to try and read and get through by Elizabeth Alexander. Anybody know who Elizabeth Alexander is? She's the poet that read the that read the poem at Barack Obama's inauguration, which apparently was widely, I didn't remember this, but it was widely panned. But this is, I think, the best poem on, I think, what dying is and why improving care for people at the end of life is so difficult. It's called Autumn Passage. On suffering, which is real. On the mouth which never closes, the air that dries the mouth. On the miraculous dying body, its greens and purples. On the beauty of hair itself. On the dazzling toddler, like eggplant, he says, when you say vegetable. Chrysanthemum to flower. On his grandmother's suffering. Larger than vanished skyscrapers. September zucchini, other things too big. For her glory that goes along with it, glory of grown children's vigil, communal fealty, glory of the body that operates even as it falls apart, the body that can no longer even make fever, but nonetheless burns, florid and bright and magnificent as it dims, as it shrinks, as it turns to something else. Okay, so now some public health numbers. So here I told you is where hospice started in 1982. Hospice has been an incredible growth industry in the United States, up to serving about 1.5 million Americans in 2013. I just looked, the most recent numbers have come out, but only for Medicare, so I don't have the most recent numbers on hospice care in the United States as a whole, but it has continued to increase, although a little bit more slowly. In the year 2000, the year that Mike helped us to start the Palliative Care program here, was really the birth of the Palliative Care movement here. This really came out of the fact that hospice was for people at home, and we weren't doing a good job of caring for people in other settings and not at the very end of life. So there's also been a huge increase in these palliative care programs to care for people in other settings. And we don't keep really good public health track of where and how people die in America. So this is the best, most recent graph that I can find from the Centers for Disease Control just for people with heart failure. But here in the dark blue is the percentage of people that die at home. And you can see, again, over these same years, from 2000 to 2014, a pretty big increase in the percentage of people dying at home. Most of that is people not dying in the hospital. Still have a lot of people in the US who die in nursing home and long-term care. So a lot that's been done to try to improve the quality of end-of-life care. And yet, so here's a paper I was not involved in, but from work that Judy and many others have done, is when we ask patients and families how we're doing, families and patients are telling us that the care that they're getting is worse. So this is over the same time period, 2000 to 2013. Again, this dramatic increase in the amount of money we're paying and the services provided for people at the end of life. But here we have unmet need for pain management. The odds have gone almost 2 that people are now saying they have unmet need for pain management. 25% of people dying at the end of life. This is, by the way, is people who are dying in all settings. This is just asking family members after their family member has died about the quality of end-of-life care. So this is across all settings. And then here at the bottom, overall care was excellent, and this has gone down from 57% to 47%. So patients and families are telling us the care is getting worse. So when Joan presents this, when people talk about this, people come up with many, many reasons why this could be. I'm going to give you a few of them, but I think in any other aspect of public health, if you were asking the public how we were doing, and they're telling you that we're doing worse, it requires us to take a step back and re-examine if we're really doing the right thing. So I have a few different pictures here. One thing that one of our nurses in the palliative care program did was to develop a handprint program for people who are dying, and this is a really nice piece from a hospital in Texas where they have an artist that actually does sculptures of the dying person's hand with their family member as a memorabilia for people. I hope that some of this talk is about learning from what we've maybe been doing wrong in end-of-life care and things that we need to change. Anybody know who this quote is by? I warned some of you that there would be some quiz questions here. This is probably a hard one. This is Oscar Wilde. Anybody Oscar Wilde fan? Okay. Experience was merely the name men gave their mistakes. So maybe we're doing something wrong, but we should learn from it. So a lot of additional evidence that maybe what patients' families are telling us is correct and we're not doing a great job in the quality of end-of-life care. So here's again, over this same time period, I show you a really large increase in hospice services. Again, for those of you who are familiar with hospice, this is really care that people are getting at the very end of life and not really associated with the rest of the medical care system for a variety of reasons. But over this same time period, we see that despite big increases in hospice care, that we're also seeing really big increases in other kinds of care that people are getting, which may or not be compatible with maybe good end-of-life care. So also big increases in intensive care unit care, people getting chemotherapy at the very end of life. A lot of these indicators that we see that maybe we're not affecting end-of-life care overall with our work in hospice. And then some of you may have seen there's been a lot of great investigative reporting that many people have been involved with, particularly in the New York Times and in the Washington Post, as well, a lot of good research that probably a lot of the care that we're providing at the end of life, particularly in hospice care, is not as good as it should be. So this picture over here on the right, the title here is "This is not the good death we were promised." This is from earlier this year. Hospice care failed my father when it mattered most. And I really like the picture here because this, for those of you who have been through this personally, you probably can relate to this when you're trying to take care of someone who's dying and trying to get good care. It often feels like this. You're just running around in circles all over the place and doesn't seem to be any rhyme or reason to the care that you're getting. And then a lot of stories in the Washington Post about hospices coming in, but not actually providing the care that people need at the end of life, lack of regulation, fraud and abuse, a lot of issues with hospices getting paid by Medicare, but not necessarily providing the care that they need. So I think when you talk to Joan about that slide about end-of-life care getting worse, that's often what she'll talk about, is that we're not doing as good of a job in hospice care as we could be. During this same time period, again, these slides all look about the same because a lot of these things are correlated. This, again, is from 2000 to 2010, and this is the massive increase in opiate use. A lot of this really came out of the palliative care movement. It's really all around the same time, where this is the one on the top here is oxycodone. You can see many other opiates, just huge increases in opiate use at cancer care and the end of life in all patients, and yet when we ask families, they're telling us that we're not meeting patients' need for pain management. So maybe opiates are not the answer, and we've also obviously caused a lot of other harm other than to our dying patients from these opiates. So I'm gonna provide a little bit of additional evidence for that opiates are potentially actually making things worse, not better. This is another study on, again, over this same time period from a big national database on symptom prevalence at the end of life. And here we have some of the symptoms that are very prevalent at the end of life, but also really exacerbated by opiates and a lot of other medication use. So here from 1998 to 2010, people are reporting a 31% increase in the rate of confusion, increase in the rate of depression, and also incontinence, all big side effects of opiates and major issues at the end of life that we don't really know how to address well. I think, and I'll give you some evidence on that later on, that I think we're not recognizing this, and we also just haven't been listening well enough to patients and families. One of the best articles I think ever written, also written in 1982, The Nature of Suffering and the Goals of Medicine by Eric Cassell. So he writes, physicians' failure to understand the nature of suffering can result in medical intervention that, though technically adequate, not only fails to relieve suffering, but becomes a source of suffering itself. And here, an adult daughter of a patient who wrote a couple of years ago about her experience at the end of life and how they kept giving her medications and more medications, and it was then hard to tell what was being caused by the medications and what was actually the dying process, and it seemed like a lot of what was being done was actually making things worse. And then one last slide, some of the evidence coming out on this as well. The top one here, these are all studies really coming out from this year that people getting palliative care, getting opiates and benzodiazepines, that it actually seems like they're doing clinically worse, that their performance status is decreasing because of all the side effects of these medications, and we need to better understand the risks and benefits of these medications, that we really need to be paying more attention to the psychosocial piece. And then on the bottom here, this one reads, in symptom control, development of new drugs is advancing at a glacial pace, contrasting to the rapid advances seen in many other disciplines. So think AIDS care is totally different. Cancer care is totally different than it was in 1982, than it was in 2000. But palliative and hospice care really haven't changed. And we've put a lot of emphasis on attention on doing these things without moving the field forward. Palliative care is an intervention that's provided mostly in the hospital setting, also for outpatients. A lot of it's physician, nurse practitioner driven, but ideally also involves other pieces like chaplaincy and tries to work with people earlier, but also at the end of life. And I think a lot of this is reflected in some of the limited effectiveness of palliative care, that we really need to improve that as well. So this is a systematic review that I did help out with a little bit. So we have a lot of research evaluating these interventions, different manifestations of them. Is it physicians? Is it social workers? Is it nurses? But all using these same very limited medications and interventions that we have for the end of life. And when you look at these palliative care randomized controlled trials, a lot of them don't show any impact on these things that really matter to patients. So only a quarter of these studies found a significant improvement in pain, maybe in part due to all of the issues with opiates not being often very effective and causing problems. About a third improved depression, only about a quarter improved quality of life. And what they're best at is improving patient and family experience. This is just one more piece from a couple of our students, and this is some national data. I think you would expect if palliative care was effective at improving the end of life that you would see better outcomes. So this is comparing hospitals with palliative care programs to those without, and a couple of other people have done these analyses as well. But you see that hospitals with palliative care programs do worse on almost every indicator of end-of-life care. These are often the kinds of things we measure because they're the easiest things to measure about end of life, but do people get admitted to the hospital? Are they in the hospital for a long time? Are they in the intensive care unit? This is probably the one that's the easiest to measure or impact is, do people get intubated at the end of life, and much higher rates at hospitals with palliative care programs than those without. And then finally, that evidence shows that this is a big thing we often talk about in a department, that end-of-life care is very expensive, but all of these interventions that we do are also very expensive, and it's obviously very difficult to show that anything lowers costs, but it doesn't appear that palliative care or hospice is really saving money at the end of life. I think for me, the biggest indicator, though, that we're not doing a good job at end-of-life care has been the physician-assisted dying movement. So 1999, I don't know if a lot of you remember this, but that was the year that Jack Kevorkian was convicted of murder for euthanasia, sentenced to 8 years in prison. I think at that time it was pretty inconceivable that we would have physician-assisted suicide here in the United States. These are a couple of things that came out after physician-assisted suicide was approved in the state of California. Ira Byrek said the public has a well of fear, anger, and distrust about the care they will receive and how they and their families will die. And the hard truth is that this is well-founded. And also just a slew of articles reflecting the suffering that people have at the end of life and how people feel like they don't have another choice. This is, I don't know if anybody read this article in the New York Times. Yeah, don't read this if you're having a bad day. It's really sad. You don't realize till you get to the end what it's about. You should not have let your baby die, but he's basically saying that the suffering from withdrawing care from his dying baby was so terrible that they should have offered this for his baby. I just pulled this down. This is the most, again, I think unimaginable 20 years ago that this would be true. This is the current map for physician-assisted dying suicide in the United States in 2018. So here, every state here in blue is authorized. I don't know if people know that it's legal now in the District of Columbia. So we've had a lot of talk here over at the medical school because we own hospitals in the District of Columbia. So it's real for us now. Every place here in yellow is a place that either has current or withdrawn aid in dying legislation. And then all the places with the navy blue squares are states with compassion and choices organized volunteer efforts. So it's most of the country, and it's not just the coast anymore. I mean, it's Montana and Tennessee. And here in Maryland, it's very active debate. All right, I have one more poem for you. Now I'm going to switch to what do we do about this? This is by Raymond Carver, What the Doctor Said. He said it doesn't look good. He said it looks bad. In fact, real bad. He said, I counted 32 of them on one lung before I quit counting them. I said, I'm glad. I wouldn't want to know about any more being there than that. He said, are you a religious man? Do you kneel down in forest groves and let yourself ask for help? When you come to a waterfall, mist blowing against your face and arms, do you stop and ask for understanding at those moments? I said, not yet, but I intend to start today. He said, I'm real sorry. He said, I wish I had some other kind of news to give you. I said, amen. And he said something else I didn't catch. And not knowing what else to do, and not wanting him to have to repeat it and me to have to fully digest it, I just looked at him for a minute, and he looked back. It was then I jumped up and shook hands with this man who'd just given me something no one else at Earth had ever given me. I may have even thanked him, habit being so strong. All right, so I want to talk about a few things I think that we can do maybe to change things and reassess and hopefully make this better for when we all come to this place. So how to better integrate end-of-life care into usual care and policy, how to implement and sustain culture change, and then how to really listen to patients and families. So just to give you a couple examples, I do believe that care can change. This is a little bit of data from our palliative care program we did for about 10 years. So we started in 2006, and we spent a lot of time trying to just normalize that it was okay to talk about these things, and also that not talking about it was not okay. So it really became I think not okay if someone was dying and no one had addressed these issues. And we talked about this at our weekly morbidity and mortality conference. And during that time period, the percentage of patients that had some type of end-of-life care, so this is a really low bar, but they either had a no resuscitate status, or they had comfort care, or we had withdrawal of life support increased to almost 100%. And we decreased the amount of time that people spent in critical care. However, and this is what you see for a lot of interventions at the end of life, really just impacted care at the very end of life and not all the care that people got before. So it didn't actually change the percentage of patients that received critical care. Ellen mentioned some of our work in quality measures. So this is the implementation and testing of some of those quality measures here. So one of the ones that we did and tested out here, this is someone with advanced cancer is admitted to the intensive care unit, is there for 48 hours. Then someone should have documented the patient's preferences for care, or that they tried. Seems like a pretty low bar. Our number here was less than 10% of medical records had anything about patient preferences in it. So this is one of our many quality improvement projects we did. We tried to address this issue with our clinicians, and Liz Foe, who's one of our PhD students. And that's all the many, many caveats of a quality improvement project in real care. But all we tried to do was to identify people who are at high risk for critical care, and then to get their regular care team to sit down and have a goals of care discussion with them. Small project that we did, but in our study group, nobody ended up getting critical care compared to almost a quarter in the control group. And we had many more people discharged to hospice, and our number of deaths in the hospital were pretty small, but only one person in our study group died in the hospital. With all these studies now, because we realize we have done a poor job of incorporating the patient and family voice, we always ask patients and families, and because it's not whether or not they got signed up for hospice care, but it's, did we really make care better for the patients and families? And particularly, so this one patient said that this was a completely awesome experience. And the reason he said that was because his physician is very pro-chemotherapy and had not wanted to stop it. And at the meeting, his physician told him that he could stop chemotherapy, and he said that was one of the best moments of his life. So, just another example of one of our projects is our palliative case management program that we ran for many years, that started in 2002 through Johns Hopkins Healthcare. Again, quality improvement project, many, many caveats, and mostly what we have are these administrative data from comparisons, but we did find that in our case management program, a lot fewer patients got admitted to the hospital. We had a lot more and longer lengths of stay in hospice and fewer people dying in the hospital. And again, trying to collect the patient's stories. Here's one of the stories. A wife called to tell me that she decided to take her husband off the ventilator. They had 5 hours left. In that time, his last words to her were, "I love you." And he also said those words to their adult son for the first time. That's what this is all about. All right, so this is a double quiz. So if you don't know this, maybe you know this, and maybe you know where this is. And I hope somebody knows this quote. Close. It's actually Tolkien. Yeah. And Yellowstone, yes.
That's really
yes. Well, at least he tried. Yeah, that's Grand Canyon of the Yellowstone. Yeah, so I think this is really key to all of you who have worked with me or done research that there's nothing like looking if you want to find something. Usually find something, but it's usually actually not the something you're after. Of course, this is about the ring, but yeah. So taking a step back and thinking, what are we doing wrong and what more do we really need to do and learn about? So we spent a lot of time developing these quality measures, and even though Alan kindly said a lot of people were using them, but nobody was really doing anything meaningful with them a lot. It's very difficult for any of us to question our own care or what we're doing, or it's very difficult to measure care, as we tell our students, but it's even many, many more times more difficult to improve it. So we took a step back and really went back and developed a survey on trying to figure out, were people using these measures? Were they using quality improvement? And if not, why? And what could we do about it? Because we don't have a system where we want to improve care, where we're open to improving care. When we have the tools to improve care, we're not going to be able to do that. So I'm just going to show you a couple of slides from this survey. These are 11 different palliative care programs in the United States and Canada. And we asked the staff a number of questions about their use of quality measures and quality improvement within their programs. And they're even the best programs that I think are really terrific programs really are not doing much or are not using these well. Again, this is all kind of real life data, so we obviously have an outlier here where they said everything was great. So here a 1 is strongly disagree and a 5 is strongly agree. And on these couple that I'm going to show you, pretty much everybody said that they disagreed with these statements. And these are they actually using any quality improvement strategies in their program to really try and make sure they're delivering good quality of care? And these are they getting training about improvement? Are they training about particular improvement projects? And are they being encouraged by their leaders to support for change? And people in palliative programs really didn't feel like they were getting any of this. And then this is some related questions. Again, we have our big outlier here, but most everybody else I think was pretty honest that they felt, they really felt, again, most people are in the disagree range, and some people really clearly having major issues, that they don't have the right systems in place, that the barriers to good quality of care are not there, that they didn't have good teamwork, that they're really not supported by leadership, and that if they were doing quality measures, that they maybe weren't the right quality measures, or they weren't doing a good job with trying to set goals and improve for those quality measures. All right, should I ask if anybody knows this one? I bet somebody does.
Yogi Berra.
All right, so I think Maya Angelou died a few days before my father did. So while we were sitting at his bedside trying to decide what to do, we read a lot of her poetry. So this is, again, she also writes some really beautiful poetry about death and dying. You all need to clearly read more poetry. I'm going to start putting it in class assignments. All right, so So Neb Ross is sitting here. A lot of this is really her great work as a DRPH student, really trying to think about how to hear that patient and family voice. And that's some of the work that we've been trying to do. So when we did our advanced directive quality improvement project in our clinic, we then really wanted to talk to patients and families about their impressions of it, and was it working for them and was it not. So a lot of patients and families really felt that it was important and that it was a really good thing to do, and to do it early, to do it with people who are healthy. So this is a quote from one patient doing that, another patient saying, we should do it now, we should do it when I'm healthy and not wait until I'm ill. But it's also really important when we're doing things in care to think about the adverse consequences, things that we did very poor job when we were, or I would say me personally, but many people were promoting opiates back in 2000 as a way to improve end-of-life care, that we really need to think about unintended consequences. And we heard some stories like this, and we hear this all the time, that advanced directives and talking about these issues really has a downside. Here's a family member that felt really strongly that because the patient had an advanced directive, that the nursing home refused to provide her compassionate care at the end of life, that she had a stroke, fell down on the floor, and they said, well, she has an advanced directive that she didn't want to be resuscitated, and so we shouldn't be doing things at the end of life. Again, also work that Neb Ross has been helping to lead about really understanding why, with all these opiates that we're giving people, that they're getting worse, and talking to a lot of people whose perceptions of care at the end of life were that the opiates were more of a hindrance and a barrier than a help. And these are some quotes from some of our patients about the issues that we just haven't paid enough attention to, how difficult it is for people that these addictive substances are being given to them, that they're really making them feel worse instead of better, that they're felt like they're being given too much, that the side effects are too terrible, and then really this really important one at the bottom, that we're just giving people opiates and we're not thinking about all the other things that we could be doing for people. And then finally, a few things that we would like to work on in addition to those areas. So I think a lot of work needs to be done in really understanding the experience of patients at the end of life and as they're living with serious illness. The care and the experience of these patients have changed so much, and we often just know what people's experience is like in that acute cancer treatment, but we don't understand the long-term side effects and what things are really like for them, and how can we care for people and provide systems of care that care for people when we don't understand their experience. So this is some work I've been doing with Jennifer Schrack, that she's been leading on, just looking at this incredibly important issue of decreasing physical performance in people living long-term with cancer survivors. And here, these graphs here in the red, these are people with a history of cancer, compared to people here in the yellow who are cancer-free. And that even if you've survived cancer, that the long-term issues that people face are incredible. And we really need to better understand these epidemiologic and patient-centered issues to be able to provide good systems of care. We're really hoping to do work to try and de-emphasize opiates and both train health professionals and do more work to try and bring all those non-pharmacologic and non-opiate quality measures and systems of care back to the top, and more de-emphasize all the medical things that we do for patients. And then Ellen, I'm excited next week that we're going to be meeting with a group from India. I just got the bios, and one of them is actually someone who's working with us on one of these projects. We were just in India, as I mentioned, where the lack of good end-of-life care is incredible. Almost everybody who presents with cancer presents with advanced cancer, seeing lines of 80 people out the door waiting for cancer care, and incredible just lack of any opiate availability, all due to a large variety of issues there. So also hoping to be able to do some work to provide better end-of-life care in places where that's not possible. And what we've been working with them there is to bring a lot of these same principles on how do we measure quality, how do we improve quality, how do we improve culture, how do we improve supports to really be able to improve quality of end-of-life care, even in settings where people may not have all the resources that we have here. All right, try to even ask about this. Take a minute. I bet a lot of you, this is not poetry. I bet a lot of you have read this book. I think it's the best book written in the last 5-10 years about quality of end-of-life care. Just a few hints.
That's all.
Yes, okay, thank you, yes. So he says, a few conclusions become clear when we understand this, that our most cruel failure in how we treat the sick and the aged is the failure to recognize that they have priorities beyond merely being safe and living longer, that the chance to shape one's story is essential to sustaining meaning in life, that we have the opportunity to refashion our institutions, our culture, and our conversations in ways that transform the possibilities for the last chapters of everyone's lives. And again, another picture from Yellowstone. It's also sunset. It's the end, but it's also incredibly, incredibly beautiful. So I thank you all so much for spending some time with me. And I think the microphone's here because this is being recorded, so.
I think I've learned how to turn this on.
Questions, I know many of you here have a lot of expertise in this area too.
Cindy, that was a great talk. Thank you so much. What about the quality of home palliative care? I don't know, did your research mostly stay inside institutions, or was that also, did it cover the home experience, and what can we do to improve home palliative care?
Yeah, so great question. We don't have that much research on the home piece because hospices really aren't generally affiliated with medical centers and hospitals, so it's really difficult work to do, and that's why most of the research has been in this setting. I think fundamentally it's really not that different, that hopefully we could be doing the same things. But I think a lot of the work on hospice care, most hospice care in the United States is provided at home, and we've been doing a lot of work over the past few years with CMS to try and develop and implement quality indicators to measure, to actually ask patients, and to also measure some of those issues with care at the end of life at home. It's really, really difficult to do. Those first few measures actually are now publicly reported and available, but don't think they're really telling us much yet. So I hope some good work will come out of that, but not yet.
Cindy, are there model programs when you talk about health systems that are really doing this right?
So it was great to, as part of that project, actually half the sites were from Canada. And do you have any Canadians here? Okay. Yes, we have a couple of Canadians. It was really impressive to talk to the Canadian programs. They had a lot of issues, of course, but because, well, I know our Canadians will appreciate this. One of my students was Canadian. I always used to start his talks with that they actually have a health system. So But yeah, a lot of great programs really providing care throughout the continuum, where here in the U.S. it's just often really fractured what we're doing, and it's very, very, it changes a lot. So here in Baltimore, what's available to patients really changes a lot from time to time, and we sometimes have good home care programs, we have good hospital programs in some hospitals, but there's just a lot of gaps, so.
Other questions, comments? Josh?
Thank you, Sydney. So interesting. My question is whether payment factors in at all to end-of-life care, and do you think it's purely a question of the disorganization of the system or medical cultural biases, or do you think payment's a factor, and is one possible reason for the difference with Canada, the fact that they have a different payment structure? Do you think the payment innovations are one way to accelerate quality? I typically, you can think of quality measures as being one stage, but then fundamental payment changes, maybe incorporating them might be the next stage.
Yeah, so a lot of you may be aware of this. I mean, if a physician sends a patient to hospice, instead of giving them chemotherapy, they lose a patient, they stop getting paid. If people don't get paid for talking to people, they get paid for getting chemotherapy, so a lot of our payment incentives are really misaligned. I think we have a lot of hope that that will change with bundled care and some of the primary care reforms. It's a really interesting topic, a lot of debate about how to try to change the hospice payment system to try to incentivize hospices to provide better care. Here in Baltimore right now, it's often very difficult to get our complex patients into hospice care because the hospices know they're going to lose a lot of money on our patients. Because hospice is a capitated program, hospices get paid the same amount every day, no matter what they do. So a patient who has end-stage Alzheimer's in a nursing home where the nurse can see 6 or 7 patients really easily and the patient's not going to have a lot of complaints is a lot more cost-efficient way to do hospice care than to try and take care of my extremely ill cancer patient with very, very demanding family member and 20 problems they're going to face on the first day. So there's been a lot of discussion of that, and I'm not sure where exactly that stands, but I think that's at least some payment reform in hospice is coming.
Any other questions, comments? Yeah, Jonathan.
Sydney, thank you. Very meaningful talk. Josh asked the question I was going to ask, so I'll ask a different one. We've seen what kids have done recently to take the issue of gun safety. What should elders do to take the issue of a good death? And I'm not joking either. What would be a consumer-oriented approach that you'd recommend?
Well, I did think about bringing some advanced directives to hand out and then have you guys witness them. Jennifer and I are doing some work on that. I suspect I don't even need to ask. I'm sure very few of you have advanced directives. Or even if you do, you probably don't know where they are and you haven't discussed them with your families, even if you do. So, yes. I think that a big reason why we don't have good end-of-life care, I mean, there's not an advocacy group. It's something that people don't want to talk about. Even a lot of people who work in this area don't want to use the words end-of-life or death or dying. Nobody wants to acknowledge that these are our issues. Every one of us have our affairs in order and have things together for our kids or our families. And it's the greatest gift that you can give people, and I'm sure you would like to have a system that works when you get there and for your families. So I think it's the public health issue that affects everybody. So
Well, I'll take that to heart. I have my advanced directive.
Oh, thank
you. Any other questions? Well, I want to thank you, Sydney, and we all want you to keep up the good work because we're all getting to that point and we're going to need it. But it's incredibly important work you're doing, and we appreciate your coming and sharing your work with us. And please join us for a reception to thank Sydney. Thank you.
Thank you all so much.